Good afternoon, everybody. It is 13:40, and we are going to make a start. So if you could all take your seats, please. I'd like to introduce our first speaker this afternoon. It is Christian Lunetta. Thank you.
Good afternoon, and I want to thank the organizers for this opportunity to be here and to discuss about the experience that ISLA developed in these last 10 years in this for the advanced care planning. And I want to start with the end of the history. At the end of the history is these big results that we obtained in our country about the advanced care plan. The first law that is devoted to put the rules about to manage the advanced care planning, about the some aspects that I will show you in this presentation very briefly. And the first was, for the first time in an Italian law, we have the concept of an advanced directive of treatment. As you know, it's an important instrument, in particular when we are involved in the care of severe disease. And I want to emphasize the concept of these articles. Yes, the first was the right of the patient to decide to consent or refusal to perform diagnostic tests or therapeutic choices, but also the importance to define and trust that would be important when the patient is unable to communicate or to be in relationship with the other. And the other aspect was, for the first time, the creation of a specific registry in all the Italian region that are collecting these documents coming from different patients, not only ALS patients. And for this, this good history was important for us because as an association we believe that a good advanced care planning it's important, as we saw in this year, for example, in experience in other countries such as Australia, UK, or Canada and US. And you will know that there are a lot of advantages to use these instruments in the management of chronic diseases such as ALS, because there is a reduction of the stress in the health professional. There is the reduction of the case of litigation related to the medical responsibility, a reduction of the rate of hospitalization in most of cases, because the hospitalization should be planned during the disease course of the disease, an improvement of the appropriateness and decrease of the health expenditure, improvement of quality of care, and increase of there are different studies that emphasize the role of a good advanced care planning in possible increment of the life expectancy related to the chronic disease. Another important article was for the shared care planning, and I want to underline that this law established that this declaration, it's important that could be recorded, but we can use written form, we can use video recording, or we can use devices that allow to the patient to declare the will about the treatment, about the procedure. And this is it's very important because a positive result after a long history of interaction with government to emphasize what is important for us to use for example, ACC devices to obtain this declaration. Another part of this law is the emphasis that the law put on the time, in particular the time of communication. In the law is very well explained that the time of communication between the health professional and the patient is a big part of the care. And for this, it's important even in the planning of our activity as a professional to include this part of the activity. In fact, for this, we emphasize this concept because the time, most of us spend a lot of time to discuss with the patient, with their family members about the disease, about the choices. It's important to put this aspect in the right position. But as I discussed before, this is the end of history. We started to obtain this law in some years ago, after some patient that claimed in the newspaper the right to declare the choice of the treatment, and if the treatment in a specific model could be stopped if the treatment is not considered useful for the quality of life, for the health, and for their dignity. And for this we performed a very interesting work inside the association to collect some concept that was included in a document. The document was provided in all the region by our chapters. The document includes the concept about as discussed before, the communication is a process. It's a process between, patient, family member, and health professional. But it's important that the patient could have the ability to decide what is the right flow of information. There are patients that, want to be informed about all the detail of the disease, but there is the right to reduce this flow information if the patient is not available to know in this moment, in that moment, all the details. And the other concept introduced in the document was the idea of the time is important to increase the knowledge of the patient, of the family member, but also of a lot of health care that, for example, for the first time could meet the patients in their activity. Other concepts that were included in the document that are now in the law, now this law, was the concept of the proportion between a treatment and what we can obtain from the treatment. And for this, it's important that patient, the duty of the health professional to inform, but it's important the right of the patient to decide which treatment could be accepted or not accepted. In this document was important because thanks to this we included in the document also 4 examples of forms that could help the patient to well define, well declare the decision. Recently, these forms were updated with obviously with the law that was approved after the first version of these forms, and the forms are for the consent to invasive ventilation or descent to invasive ventilation, or to establish when, for example, is the time to stop the invasive ventilation, or if the patient decided to stop the invasive ventilation when the patient reached the, for example, locked-in status. This is briefly the structure of, for example, of the first document. The second one about the descent of an invasive ventilation, with the part in which is well defined the awareness of some information, and at the end the declaration of the patient. The same for the stop of the invasive ventilation, and the same for this one. And so this discussion want to emphasize that it was important for us, first of all, to clarify some aspect even inside the health professional, because for this aspect, in some cases the health professional not are generally well informed, and for this, thanks to this, we emphasize the rule of the advanced care planning, the concept of the awareness, the concept that there is a difference between an advanced care planning and the concept of euthanasia, the rule of the fiduciary representative, also trustee, and the concept about that could be the time that his patient could refuse or stop what we decided before. And but this history included also not only document, not only paper, but also an activity that we performed in all the Italian region to discuss about this aspect. In particular, we developed in this 4-year 64 training course involving health professionals. And this is the number of the professionals that participate to this training course, and the location of the course. We recently performed a survey including these professionals to understand how was the feeling after the training course, and the result was very interesting because first of all, the majority of them declared that the training course allowed to increase the awareness about the advanced care planning, the importance of the advanced care planning. For the first time, they was were discussed the importance of the time that all the professionals spent to talk, to discuss with the patient and family member. Another result of this survey was that thanks to this work, changed the idea of regarding the advanced plan candidates. I think it was one of the most good results. Few of the health professionals used the document that we prepared to declare the 4 document, but this is in contrast with another aspect. We received a lot of requests by the patient directly that used the document to define and to communicate the advanced care planning. Another other two results was, yes, in the case in which the professional were used the document, the feeling was positive of this of the utility of the document, but the majority asked to continue this work to implement the knowledge about the advanced care planning. Thank you for your attention.
Thank you. Brilliant timing. Any questions for Christian at all? I have one question. You talked about doing training with professionals in the use of this document. Can you tell us a bit more about that? What kind of methods did you use in that training?
Yes, generally this training course included 2 days. 1 day generally for a frontal in which frontal teaching, in which there is the clarification about some concept about the advanced care planning, but the second day is performed in some cases with exercise example in to understand how is the best way to develop an advanced care planning. But was very interesting because in some region there was a very active role of the patient that were involved in the training course to not to learn but to teach and to have the time to discuss with the health professional about very, very pragmatical aspect of this. And I was very interested because even the speaker were very happy after the training course, because it was a good experience and increased our, okay, this concept for us is as a priority.
Okay, thank you. We have a question just over to the left. Thank you.
Thank you very much. My name's Joan Murphy. I'm a speech and language therapist and I'm a consultant with Talking Mats. And I'd just like to ask if you provide some kind of visual help to people, visual images, pictures, symbols, to help explain the whole process of ACP for people, because quite often the text in documents is a bit dense, a bit heavy for people.
Absolutely, absolutely, because in most of cases are it's not simple to explain some aspect of this process. Firstly, because generally we start to discuss when the patient is not in the last stage of disease. And for this, it's important to help the patient even with a picture or even with a graph to understand some detail that could help the patient and the family member to define a possible care plan. In fact, the concept of the time, yes, is not the time that we spend only to discuss, but the time to repeat the discussion. And in some cases it's not simple. In my experience, there are some cases in which there are a lot of meeting to define this declaration. And for this it's important to start very early. Yes, taking account the importance of the details, but the use of instruments to help the learning, it could be very useful.
Okay, thank you. Okay, thank you very much for your presentation. I think we'll move on. Thank you. So I would like to invite our next speaker, Dr. Rachel Thames from Oxford.
Hi, and thank you. Just want to start by saying I'm really delighted to be here this afternoon, and my presentation's around what is known about children's psychological support needs when a parent has MND and the available services that are out there, or what a good intervention might look like for children. And I can hold my hands up now and kind of say not very much, basically, and I could keep this really short, but I have still managed to fill 15 slides of some of our reflections and thoughts, so hope you'll find it helpful. So have no disclosures, but just to give you some context. So myself and my colleague Audrey Daisley, who can't be here today, but this is very much her presentation as well, are both jobbing clinical neuropsychologists working for the NHS in Oxford. So we work in a neuro rehab service supporting people with a range of neurological conditions, including MND. And Audrey leads on a particular bit of the service, which is specifically family support service. So she will work with relatives and children who are living with a neurological condition in the family. And the outcomes for today are to have increased awareness of the issues affecting children who are living with MND in the family, to kickstart thinking what good support might look like, and to highlight the importance of further research and the development of services and networking in this area. So as I go through, I think what I'll be highlighting is that there isn't a lot out there written in the scientific literature, but I want to stress that that doesn't mean that there aren't pockets of really good practice and innovation going on, and I guess that's one of the reasons why we wanted to present today. You know, it's really good to find out what's happening out there and what's maybe not being captured in the hard literature. So we'd really stress the importance of networking and letting us know if you've got a really good model, really good services for children in your area. So in terms of challenges to children, we know that MND presents family members with a unique set of adjustment challenges, and we know more about how adult relatives are affected. There's, across a range of neurological conditions, quite a lot is written around spouses, carers, adult relatives' experiences. And we know that MND typically results in profound and complicated losses for the person and the family around them, and that there is a bit of a reciprocal relationship in that when a family member isn't doing as well with their psychological adjustment, it can have a big impact on the person with the condition and vice versa. So it's really important to consider family members' needs in their own right, but also in terms of how it's going to impact on the person with MND's well-being as well. So we know that adult relatives of people with MND typically present with increased levels of psychological distress, so increased rates of anxiety and depression. But much less is known about how children are affected, and there is very little literature out there on this. We know little about how having a close family member impacts on children, how children cope, or how best to be supported. So we recognise, if we look at the wider literature of children who have a parent or close relative with a neurological illness, that they are more vulnerable to psychological distress, and also from the wider health literature as well, when we look at conditions like cancer, we know the group of children are vulnerable, but when we look at the condition-specific literature for MND, there is very little that is out there. So we just found a couple of studies, and it may be that we're missing things, so do say, either do say at the end or email us if we're missing any research studies that you're aware of. But we found the first one is a qualitative study, so a small number of children. So I think there's a sample of 7 older children who were caring for a parent with MND, and they reported that they lacked information about their parents' illness, particularly around diagnosis and prognosis, and particular issues that they flagged up were around coping with changing family roles and the impacts of their care responsibilities on education and social life. And then another study, Calvo and colleagues, was with a larger group, so comparing 23 children who had a parent with ALS to children with healthy parents, and they found that children were at increased risk of emotional and behavioural difficulties. So they found difficulties in terms of internalising symptoms like anxiety, depression, withdrawal, and those findings are generally consistent with the wider neuro and health research. And also, I mean, it sounds like stating the obvious, but the International Resiliency Project, which was a large international study of children, just highlighted that death of a parent is rated by children themselves as the greatest stressor that they can encounter in childhood. So does it fit clinically? Say yes, it often feels as though children are the hidden victims and they're overlooked in service provision. And because there's so little research out there on children's psychological needs, there's not much guidance on how best to support them. Key issues that seem to come up in the literature and from clinical experience are around understanding the diagnosis, its causes and what that means, understanding and coping with changes and gradual losses over time, restriction of life experiences, fearing how others around them might respond, so thinking about how friends may be when their relative dies, and conflicting emotional responses and having little life experience to draw on. And on top of that, you've obviously got the child's developmental age and their understanding of things like the concept of death and dying. And that is happening while parents themselves are struggling with all of the issues around uncertainty, grief, managing day-to-day changes, trying to live well while managing the deterioration and preparing for the future. So child-focused interventions, I've already said there's very little out there. We actually couldn't find anything in a systematic review that we carried out a few years ago, and that was on psychological interventions across a range of neurological conditions, not just MND, but we couldn't find any published studies. And as I said, that doesn't mean that there's not really good work out there. So we know of things like Hope Loves Company in America, which seems to be a really valued resource for families. So they offer interventions like counselling and camp-style programs, so with real emphasis on social connections and children coming together. And we're unaware of anything like that in the UK, but it doesn't mean it's not happening. And I know from a conversation I had earlier this morning, I've heard that there's an MND nurse who's running quite an informal social group for children in Milton Keynes. So I think there are things that are happening and that families are valuing, but maybe we're not all aware of it or they're not being written up. So NICE guidelines in 2016 place focus on signposting families to help. So they say it's really important that we recognise the needs of all family members and then we refer them on, or they're signposted on for psychological support or respite. But the question is where and what, what is available, what does good support look like? So these are the sort of things that we thought might be available for families. So we know there are fantastic MND Association resources, and we were shown some of those earlier. So there are great resources for children and in lots of different formats. There are the MND care centres. We wonder if there's variation in what is offered in terms of family and children's support. In Oxford, so within our centre at the OCE, so that's an NHS service, we do offer family support, but we have very long waiting times, and the feedback we often get from families and from professionals is that as a service we're just not responsive enough and we can't offer enough support in a timely way. Hospice and palliative care services, I think, are often involved in providing support to children. And then there are a range of specific child bereavement services, so things like Winston's Wish. We have Seesaw in Oxford. There's the Children's Bereavement Network across the UK. So there are lots of specialist bereavement services for children offering resources and support, some groups, but again, it may be patchy across different areas, and young carers agencies. So generally our impression is that there are a few dedicated family support services or intervention programmes that are offered within the NHS. And the next question we thought of are what are the barriers to this work? And this is a little bit tentative because we don't know, and these ideas are just coming from other work we've done with other neurological conditions. So Audrey and I ran a couple of large surveys several years ago now, but national surveys of MS services, and then there was one that was also around acquired brain injury services. So we were just contacting professionals to ask them about their experience of working with children, what they were offering, what their feelings were about working with children when a relative had a neurological condition. So with the MS survey, we were mainly asking MS nurses. And with the brain injury survey, it was a whole range of neuro-rehab professionals. And what came out of those was that everybody was very favourable about supporting children and saw it as an important area, but the majority were not doing this, other than maybe providing information. And the main reasons were contextual, so things like lack of support, so lack of support within the workplace, hit and resistance from parents and that natural tendency that some parents had about protecting their children and not wanting to upset them. Parents fearing that they might be seen as not coping if they raised issues with the health professional, or people just not being aware of what services were out there. And then there were also a whole range of practical issues, so things like lack of time, money, access to training and supervision, and then personal issues like anxiety and feeling it was out of their role. Based on our experience, we would say what children need is complex, that the way children cope with family illness is complex and it's mediated by a number of factors. Age-appropriate information is hugely important to help them make sense of it, but we also know it's important to target other issues that are crucial in building resilience, emotional resilience. And the key features there are around connection, so meeting others and having that kind of support, and looking at enhancing coping and the strategies that people use. Skip that. And one example of an intervention that we've just been thinking about is group intervention for children who have a parent with MND. We run a very similar group for children with MS. That is really well received, and it emphasises those resiliency building ideas. So this idea of bringing together a group of children in a similar situation, providing them with info, but also looking at the things that we know are important for resilience. So looking at their existing resources and strengths and role models, and trying to send them away with a bit of a toolkit of things that they can try when they feel the going gets tough. So we just wondered if that could be adapted for children with MND, and we're not sure. We think there are specific issues and differences and difficulties, and one of the key things is around possibly encountering more reluctance from parents, a wish to protect children from the idea of death if they haven't been having those conversations. It definitely wouldn't be the right forum for children to be learning about the prognosis in, so that would need really careful consideration. But would there be a benefit of bringing children together and running some kind of programme where they can share ideas and experiences and build up their skills? We'd also need to consider things like follow-up and bereavement support, what it might be like for the facilitators in terms of their own emotional reactions and support needs. So it's just an idea at the moment. We've met with MND colleagues in Oxford and the MND Association, and we were thinking about a research grant to look at it properly and evaluate it properly. But I think we've stopped, and we're just thinking at the moment if that's the right way to go, or if we should do more general research first. So we think good child support would target those processes known to be important in enhancing resilience, and it would be strengths focused, focusing on what's around the child and what might help them at times of difficulty, and would be available through the whole journey of the illness, so from the point of diagnosis through to bereavement and post-bereavement support, and support the parents and other family members on how best to support children. I think that's a really big issue. So parents often tell us they have the information, they know about the resources for children, but it's still very difficult to have those conversations, and it's around how best we support them and skill them up to be able to do that. So what next? We just feel that a lot more research is needed in this area to guide all of our work to ensure it's based on good practice and the child's lived experience. So we're just looking at funding to carry out research into identifying information and support needs, and just build on that very limited evidence base that's out there. We've also been thinking about surveying professionals' experiences and attitudes towards supporting children. So like we did with those other conditions, but thinking of something that's much more MND specific. We'd like to find out what else is out there, what sort of models people are using, if they're running groups or if they're referring on to really good palliative care services. It'd be great to know what works. And maybe consolidate that link with Hope Loves Company in the US. It'd be really nice to find out more about that and how that works, and maybe something similar could happen in the UK. So in summary, we just wanted to stress that child relatives are really important in their own right, and they're potentially a high-risk group who are vulnerable to difficulties. And I think NHS services generally are not meeting their needs, or they're slow to address the needs of children. But potentially we can see positive outcomes, positive personal growth. So literature in other areas of neurological illness has also shown the positive growth that children can report through supporting a parent, living with a parent through the journey of their illness. So the challenge for us really is just to increase children's visibility in service provision, literature and research and clinical practice. Okay, so thank you for listening.
Thank you. We do have a question. There's a lady with her hand up just in the middle on the fourth row back.
Hi, thank you very much for that. I'm Karen. I'm a physiotherapist and also a researcher in Australia. And I've just finished a PhD on exploring the experiences of families living with younger onset dementia. And what you've just said is just exactly what is happening with that group. And I think it's not just disease specific, I think it's very general all over, you know, all diagnostic groups.
Yeah.
I just wondered how you get over the age issue of actually speaking to the children, because that's a big, big thing. And the health professionals I've talked to have called the parents the gatekeepers.
Yeah.
And the parents struggle, they don't want to upset the children. They've already got emotional baggage, was what one of the parents said. I don't want to add to their emotional baggage. And there doesn't seem to be services where the children can actually go to anyway. So they think it's a waste, you know, and the children are really, really psychologically very distressed.
Yeah.
So I just wondered how those young children that are still, you know, have to get parents' consent to go anywhere. How do you overcome that?
It is really, really difficult, because without the parents' consent, can't do anything. So, and I guess as a psychologist in our service, we tend to see the children where there are real issues. You know, it's kind of, and that's why I think we like the idea of a group intervention, which is much more preventative and about skilling up all children. But in terms of trying to get parents on board, I think we just go down the line of really trying to normalise it and just say, this is what we know generally helps children. You know, even if you're not talking about it as a family, they'll be picking things up, they'll be hearing things, and what they're thinking and their kind of conceptions about the illness you'd be really surprised. So we know it helps for them to have the information. But I think if you hit complete resistance of parents, it's really difficult. I think it's a case of talking it through, giving them the information, and just coming back to it, you know, checking in, like having like almost like a family checkup when you see them, and just say, do you feel ready, or do you feel it's a good time to talk this through? But really hard, and it's really understandable as well. You know, as you said, they're going through so much, and there's no clear answer on when's the best time and what to say. So.
Okay, thank you.
Professionals often, do seem to have just that concept that they're working with adults as well, so they struggle with children.
Can you say that again, sorry?
A lot of the health professionals think that they're going into that job just to work with adults and struggle with the concept of working with children.
It is hard, and it is, you think, what's my role? And so that comes up a lot, like with the surveys we've done before. And it is really interesting, you know, we just ask people, you know, as a kind of jobbing physio, say, going into someone's house, if there's a child there, you know, do you explain why you're there and who you are, what your role is? And again, people are guided by the parents, but it is difficult to. It's so complicated supporting like the adult who is your patient, but then there is this whole family system around them. So,
Thank you. We've got time for just one more question. Gentleman down here.
Thank you. And I wonder if we should do more instead of getting into researching this. Why don't we
just do
start?
it? Yeah.
Yeah, and hope Love's company is a great thing, and getting the kids together solves a lot of these problems. And we are in Iceland, we took a group from Hope Love's company, and they just spent time being themselves.
Yeah.
And that's very important.
Yeah, I think you raised a really good point. It's like when I was saying about our group and like applying for grants, it delays the whole process. So I think there is real value of going for things as well. I think the point I'd make with the soft literature is if you're going for it, it's just really helpful then for professionals to write that up. It doesn't have to be a big study, but just to have it out there somewhere so that people know that there's a particular group or, you know, that people are finding benefit in it is really helpful just to build the networks and build that evidence base. So thank you.
Thank you very much, Rachel. We do need to move on to the next
Cheers.
speaker now.
Thank
Thanks
you.
a lot. Okay, so I'd like to invite our next speaker, Jane Martin.
Hello. My name is Jane Martin. I'm an advanced nurse specialist from the Macmillan Unit Hospice down in sunny Dorset. And we're a 16-bedded hospice, and we cover around 250 to 300 community patients at any one time. Our service is jointly funded by Macmillan Caring Locally, which is a local charity, and the Royal Bournemouth and Christchurch Dorset NHS Trust. We cover both urban and quite rural as well, so we have a real mix of patients. My experience is in specialist palliative care, but as I've been in a specialty for several years, I've developed more of an interest in the neurological life-limiting diagnosis of our patients, and now cover all the patients that are diagnosed in our area with MND, and that can be anything from about 15 to 25 patients at any one time. Ali, one of our senior physiotherapists who's sitting down here in the row, if there are any questions later, both herself and me have developed some training for our team that we'd like to share with you today. This is Dorset. As you can see, it's very lovely and it's very sunny if you'd like a nice holiday. And this is where we're based, the Specialist Palliative Care Service. We look after all people living with MND in East Dorset, from diagnosis right through to the end of life, both in the community and in the hospice. As most of you know already, non-invasive ventilation is a symptomatic and life-prolonging treatment that is now widely used in the care of people with MND. These people experience progressive muscle weakness and wasting, and this can include the muscles of respiration. NIV assists patients' breathing as their disease progresses, in a similar way to an electric bike when you tire from cycling. Patients can become dependent on NIV as they approach the end of their life. Book published the first large multi-centre randomised controlled trial in 2006. And this was a key milestone in MND research. It showed for patients without swallowing and speech symptoms, NIV increased survival by up to about 18 months. There was also significant improvement in symptoms due to hypercapnia, such as morning headaches and wakeful nights, for those with or without bulbar symptoms. In 2010, NICE published guidance for NIV in people with MND. With wide implementation of these guidelines, the use of NIV has markedly increased. The Respiratory Centre at Southampton Hospital, which is our nearest specialist NIV service, was rapidly expanding its home ventilation programme at that time. From 2010 onwards, we saw the impact of this on our service as people living with MND were increasingly choosing NIV and dependent on this approaching the end of their lives. Some patients, however, did decide to stop using their NIV in our hospice, and this actually was one of the trigger points for this project. So utilising the need for training for the service improvement, we utilised firstly staff feedback. Staff feedback and reflections following NIV withdrawal showed that some had found this distressing, and there was a lack of clarity regarding the law and ethics around the context of withdrawal of NIV. As we know, sometimes it's more difficult to contemplate withdrawing treatment than to actually start a treatment. Staff said things to us like, "Is this assisted suicide?" And I felt like I'd killed her when I took that mask off. In addition, there was a lack of competence in practical management of the equipment. I often quote a saying to my colleagues, and I'm sure some of you have probably heard of it, the post hoc ergo propter hoc Latin. For since event Y followed event X, event Y must have been caused by event X. And this is very pertinent when we think about why our staff are distressed on the withdrawal of NIV. Because they feel that the death of that patient was followed very quickly following the withdrawal of the mask, and therefore the death must have been caused by them withdrawing the mask, when actually they have died from their disease of MND. So we looked at the evidence. Looking at some of the evidence, Baxter published qualitative research into the effects of NIV withdrawal on families and healthcare professionals, suggesting that the terminal phase of MND could be unexpectedly rapid. Early advanced care planning was advocated, acknowledging, however, that this can be really difficult. Deciding about NIV is just one of the many difficult and complex advanced care planning decisions the person living with MND has to make through this journey. And indeed, Fall in 2014 emphasises that early decision-making due to the risk of the onset of cognitive changes can further limit future discussions. Additionally, Harris in 2015 suggested that allied health professionals need to listen to a person's existential concerns for life and death early in their illness trajectory and while they can still communicate. And recent evidence actually supports this. Levi in 2017 suggests that when people living with MND fail to communicate their future wishes and their wishes for medical treatment, the consequence is often suboptimal decision-making during a crisis. So identifying the training needs for the service and our quality improvement. An audit of our hospice found that between June 2014 and September 2015, there were 303 days with a person with MND in our hospice, and of those, 59 days where a person was using NIV. This helped quantify the need for ward-based training. Hospice staff lacked confidence in when to start these discussions, both around the appropriateness of commencing NIV or not, and the future possibility of withdrawal of that NIV. There was a perceived complexity regarding the decision-making, and some felt that this was a medical responsibility only. This was despite an advanced level of communication skills around advanced care planning and end-of-life care that's inherent within a hospice NMDT. Simmons in 2007 found that some hospices are not familiar with the use of NIV, and indeed, at that time, our hospice staff lacked experience with practical management of the equipment. So looking at discussions. Initially, we reviewed the NICE guidelines and we drew out these main issues. Firstly, discussion. There were 4 suggested points in the patient pathway for discussions regarding the decision around NIV. Firstly, soon after diagnosis. Secondly, when monitoring respiratory function. Or thirdly, when it deteriorates. Or lastly, if the patient actually asks for the information. Secondly, we looked at assessment, selection, and competencies. NICE suggested 3 monthly respiratory screening and that team members who provide non-invasive ventilation should have appropriate competencies. Thirdly, we looked at withdrawal. NICE recommended that discussions regarding withdrawal were initiated while patients were considering NIV, although detail re the practicalities of withdrawal was limited and seems to be directed to a professional with experience. This was something we had no experience of as a team, and specifically for NIV and MND, although withdrawal of treatments is not unusual in the context of specialist palliative care. We are very used to withdrawal of fluids, nutrition, antibiotics, for example, but often the act and then the result of death is then longer than in the withdrawal of NIV. So aims, and what did we want to achieve? We wanted to design a hospice training program that would cover the following: to help staff become confident to discuss NIV, both from diagnosis and help patients make decisions, screen, and refer the right people at the right time. We wanted to educate all palliative care staff regarding relevant ethics and law. And we wanted to train staff to manage the equipment and interfaces, especially out of hours, when usually the problems seem to arise, and lower the risk of complications, for example, due to pressure from the interfaces. We also wanted to educate regarding the withdrawal of non-invasive ventilation, and we also, importantly, wanted to give an opportunity for staff to reflect on difficult cases and to be able to ask questions. So starting in 2013, in November, we sat down as a multidisciplinary team to reflect on 5 recent cases of withdrawal of non-invasive ventilation within our hospice. We then attended external training. In 2014, 4 hospice staff, including ward staff, physios, and myself, we each attended a 2-day British Thoracic Society NIV course, and we attended the King's MND Centre Study Days, which are run in collaboration with St Christopher's Hospice. The physiotherapists of our team gained spirometry competencies at Bournemouth Hospital Respiratory Physiology, and my colleague, physiotherapist Ali Lycett, completed competency training in NIV at Southampton Respiratory Centre on an honorary contract. In 2015, we completed further respiratory literature searches on respiratory screening. We also sought advice from our MNDA Regional Care Development Advisor, Louise Rickenbach. Starting in 2015, we developed local staff competencies. A plan for a 3.5-hour training session, which was reviewed by Southampton Respiratory Centre. This was a mix of presentations and practical sessions, of which included respiratory function in MND, the practical management of the ventilators, and discussions and decision-making. In addition, we presented professional guidance on the law and ethics that support the decisions surrounding both commencing NIV and withdrawal of NIV. We used resources from the BBC Radio 4 programme Inside the Ethics Committee, which addressed the uncertainty and the conflicts that arise in a team when staff have differing ethical understanding and values. A Macmillan unit pathway was started, and we found other hospices nationally were also trying to write very similar pathways to what we ourselves had developed. We'd also designed a respiratory screening tool for use by the hospice physiotherapists. And in collaboration with the Dorset MND group, we developed a respiratory care pathway with local consultation from palliative medicine, neurology, and respiratory consultants. NIV was added to the hospice inpatient nursing care plan in collaboration with our clinical lead. This is the Dorset Respiratory Care Pathway that we wrote collaboratively, which is on the MNDA and Dorset CCG websites. Its local use is intended for primary care and for non-specialists. Discussions and ethical decision-making are actually a key part of this pathway. This was as part of a wider set of Dorset pathways for MND, including nutrition, communication, and, importantly, end-of-life care. While we were doing this, NICE published updated MND guidelines that incorporated management of NIV. And the Association of Palliative Medicine published detailed draft guidelines for withdrawal of NIV in MND, which we decided to use, and we actually discontinued the development of ours. So the training that we actually delivered between September 2015 and February of this year. We delivered 5 3.5-hour training afternoons. All specialist palliative care trained staff attended, including ward and community nurses, consultants, registrars, medical and therapy staff, Macmillan Day Centre staff, and the discharge coordinator for the hospice. It was also attended by our MNDA Regional Care Development Advisor and some local physiotherapists who have an interest in MND. We collected feedback and we asked staff to rate themselves on the following 3 questions on a scale of 1 to 4, where 1 was poor, 2 was adequate, 3 was good, and 4 was excellent. 44 staff in total completed the evaluation forms. You can see here the 1 to 4 rating along the horizontal axis. Blue is before the training, and the green columns are for after the training. For question 1, this was regarding the recognition of respiratory failure in MND. 93% rated themselves good or excellent after the training. And actually this is important, as recognizing signs and symptoms is a trigger for having NIV discussions. Secondly, when asked to rate their practical confidence, 88% rated themselves good or excellent after the training. In real terms, the staff are more confident in their skills. However, the best results were in the area of legal and ethical frameworks, where 97% of staff rated themselves good or excellent after the training. This has supported both competent and confident NIV withdrawal, both initially within the hospice and more subsequently out in the community. And this has had the added benefit of supporting many of our primary care teams who obviously don't meet this on a regular basis and need that additional support. Therefore, our 3 key points for today, to summarise. Hospice-based MDTs can be confident in NIV discussions and decision-making, including withdrawal and practical management from diagnosis right through to end of life. NICE guidance actually suggests that a multidisciplinary team can improve care and extend life for people living with MND. Our second point is that staff need training to be confident and competent. Hospice-based palliative care MDTs can develop the skills and confidence to manage NIV through from diagnosis to end of life. And lastly, our third point is specialist palliative care teams based within a hospice are ideally placed to deliver this. Hospice-based teams help the right people select NIV at the right time and for the right length of time, recognising that they may wish to discontinue this. Extending life is not everyone's priority, and NIV is not right for every person living with MND who fits the criteria. The importance of discussions with appropriate discussions within advanced care planning is very much part of our hospice care. And a palliative approach is very much about nurturing within the MND and our mindset, not so much about fitting a criteria and a set of numbers. Specialist palliative care is about the whole person, respecting their individual preferences, attitudes, wishes, values, and beliefs. And many of the skills inherent in a hospice team can be used to provide and support this care. I thank you very much for listening, and I'd like to thank our local Motor Neuron Disease Association group of Dorset and the New Forest, who have sponsored our attendance here today. Thank you very much.
We are running a little late. Thank you very much for that, Jane. We are running a little behind, so do we have any questions at all? Perhaps take one. Or if not, you could find Jane in the break, maybe. Is that okay? Thank you. Thank you, Jane. So our final speaker before afternoon tea is Wendy Bennett.
Good afternoon, and thank you for allowing me to speak about an area of our work that we feel passionate about. As we all know, ALS MND is devastating a disease, not only for the person living with MND, but also their families. The Royal College of Nursing, which is a UK national nurses union, has quoted that a person with ALS MND can need as many as 18 health and social care professionals to provide care at any one time. So you can imagine that once that person dies, their carer is left and often can feel abandoned. It is hoped by the end of this presentation that you may be inspired of thinking of ways you can support people after the death of their loved one. Of course, you might be doing this already, but I'd like to share our way we help people who've been bereaved. We all know that hospices are pioneers in bereavement support. Our team realised that some of our families haven't been involved with the hospices, so might be missing out on their support. Once we realised there was a gap in our service, we decided to organise a memorial service specifically for families who had lost someone to ALS MND. In 2014, we held our first memorial service and 64 people attended this. After this, our bereavement support framework was evolved. Today then, I'd like to cover 3 areas. To introduce our bereavement support framework, including our annual memorial service, to be clear about the limitations of our support, and some practical recommendations. I thought we'd start with a quote from one of the most respected women in British nursing, Dame Cicely Saunders. She says that care and bereavement should be as important as the care we offer for the person at the end of their life. These memories are crucial to how the carer will cope in the long term in bereavement. So like most ALS MND care centres, we are a regional unit in the northwest of England. The population is around 1.6 million, and we live in a mix of urban and rural settings. We are very much a nurse-led service, and like for most of you, we care for people from diagnosis until their death. This is through our clinics based at the local hospices and as well as home visits. We are able to develop relationships not only with the person living with MND, but their families too. Prior to setting up our bereavement support, we came to feel as a team that we were sort of abandoning our families as we've been so involved with them during the time that their loved one was alive. As with most areas of ALS, there isn't any specific research or guidelines to draw upon. However, the National Institution of Health and Care Excellence, NICE, has published guidelines for the end of life. They state that professionals must maintain contact in bereavement in both the short and the long term. NICE doesn't define what long term is. But in our service, we offer support over the first 12 months of bereavement and then maintain contact with the families through our annual memorial service. I think it's important too that support is offered from the people who cared for the family member. Oon suggests that people appreciate care and bereavement from the people they trust and know well. The MND Association published a report in 2016 after the government called for evidence on improving care for carers. As you can see on the slide, some comments were quite harsh that carers felt dropped and everyone left once the person had died. Knowing that most of the multidisciplinary team and carers visit regularly meant their house was very busy with visitors from different disciplines, and then suddenly we're not all there and life is extremely empty without the demands ALS places on the carer. The report concludes that by saying that it is vital that the experience of people caring for a person with a terminal illness is recognised and valued, and that they are supported accordingly after the person has died. We as healthcare professionals have a role to play in supporting this period of transition. With this in mind, Bridget Whitehead's study shows carers go into bereavement process physically and emotionally exhausted. Oon adds that they deny themselves time for themselves and, even more importantly, sleep. We wanted to show them that they're not forgotten. This had a practical challenge with the team covering such a large geographical area, and so the support needed to be indirect. So, this is how our bereavement support framework works. It's a simple and time-effective way of keeping in touch with people. I think we probably spend about an hour a month concentrating on it. On death, we always ring and send a sympathy card to the carer and their family, and their key specialist nurse, if possible, tries to arrange a bereavement visit. Around 6 to 8 weeks later, a handwritten card and poem is sent out to their next of kin. The words outline that we're still thinking of them and invite them to contact our team if they would like to. Actually, not many people ring at this stage. Another card and poem is sent out just before the first anniversary of their death. Again, reminding them that we are still thinking of them and appreciate that life is probably still difficult. This time we often can receive emails, cards or phone calls, as they are touched that we still remember them after 12 months. It is often nice to catch up with these people because they've started to heal and get on with living their lives. Admittedly, there's always a sadness when they talk about the person that they've lost. We decided on the timings of these cards after reading a study by Vasha Hassi and Hottenson. Both authors felt that phone calls, cards, and if possibly an annual memorial service helped the person feel that there was a continuity of care and they were not forgotten. We certainly have had a positive experience of this. Vasha Hassi's study goes on into more depth, stating around 6 to 8 weeks post-bereavement, friends start getting back to normal, and the realisation that that person is not coming back starts hitting them. We recently sent out a service evaluation questionnaire out to people who've been bereaved since we started the service in 2014. This was just to see how people felt about receiving cards and if they had any other suggestions that I'll discuss later. As you can see, people appreciated this small gesture. It was so good to receive the cards because it made us realise that you understood how hard it is to lose a loved one to this terrible disease. If I can draw your attention to the second comment, the first 12 months was a blur. This reflects what Bridget Whitehead highlights in her study, that carers are left physically and emotionally exhausted and can take 12 months for them to recover. There were lots of lovely comments, but the main theme is they appreciated they hadn't been forgotten and we still cared. A Time to Remember is our annual memorial service that takes place every May. It's a time where people can sit and remember people they've lost through poems, readings and music. For practical reasons, we hold it in the hospital chapel, and it has a spiritual atmosphere. but I must emphasise it is a non-religious service. We had our first memorial service in 2014, where 64 people attended. The numbers have been slowly increasing, and this year we had just over 100 people for us for the service. It's been noticed that a few people have attended every year since 2014, but the majority of the attendees come for around 2 years and then seem to stop coming. One comment we received from our service evaluation was that she attended the first year, but after that she didn't feel she needed to come again. Another felt after 2 years of attending, she felt she was getting stronger, and she felt that it would be better to remember her husband pre-motor neuron disease. Everyone who's been bereaved over the last 12 months receives an invitation. Also, the people who have previously attended the memorial service are automatically invited to the following year. This is the inside of our invitation. We hold it at the hospital chapel at 3 o'clock on a Sunday afternoon. We ask our attendees to reply to say if they are intending to attend, so we have an idea for catering and organising the service. We also ask their permission to read out the person's name who's died. Their name is read out during the act of remembrance in the service. We often find people who can't attend will still send their name in to be read out so they know that that person has been remembered. With these people, an order of service and if possible the gift we give during the service is sent out to them. The order of service follows a collection of poems and readings which members of our motor neuron disease team take turn in reading. The chief executive of our hospital attends and she always takes part. We try and choose poems that give people a sense of hope as well as a time to remember them. In the middle of the service, there is an act of remembrance where the bereaved names are read out and candles are lit in their memory. This is a lovely part of the service where nurses who have been involved with these read out their names. It's tricky though not to cry at times. Music plays a big part in the service, and this is carefully chosen. It gives people a time to reflect and the atmosphere is lovely. At the end of the service, we invite people to add a card to the memory tree, which is given to them as they arrive. They can write their thoughts on this card and add to everyone else's memories. As you can see from the screen, here are a few cards that people have added to the memory tree. Another year without you, I still miss you, but the memories never fade. Neither will my love for you, love from your best friend and hero. My beautiful mum, I miss and love you every day. I miss your smile, lots of love. When we look at the comments, you start to realise the devastation MND has on families months and months after that person has died. When the families have put their card on the tree, we like to give them a small gift to take home. We try and relate it to the forget-me-not flower, so they've received forget-me-not seeds, a poem, or a bookmark. This year, I decided to give them a little plant pot with a candle. It needed a forget-me-not sticker cutting out, and then it needed varnishing. Ah, that's nice, I thought, until I realised I had to decorate 90 more pots. A word to the wise, keep the gift simple. After the service, people are invited to also write in our book of remembrance. Not too many people take up this offer because I think they've said what they needed to say by adding the card to the memory tree. It is just giving people as many ways to remember their loved one. Then it's coffee and cakes. This is a lovely time where people will chat to people. This is a lovely time where people chat to the MND team, and it's lovely to hear their family news. Often it's about new grandchildren, or going away, or just feeling better. Admittedly, there are still quite a few who are still struggling. 1 or 2 people have come for 2 to 3 years and have started recognising other people, so they are starting to chat together. Then they go home and we go, phew, another year done. Here are a few comments from our service evaluation. Of course, they're all lovely. We didn't receive any negative feedback, but of course we didn't receive all the questionnaires back. Out of the people who replied to our service evaluation, a few people suggested they may have benefited from a support group. Logistically, it would have been difficult to coordinate this group due to time constraints and, again, the large geographical area. There isn't a lot of information in regards to bereavement support groups. I am aware that CRUs and the hospices, of course, do offer this kind of support. Reid et al. Have studied bereavement support groups and feel they are valued, but you have to be mindful that people don't become too dependent on the group. I think we need to be a little bit more proactive in signposting people to charitable organisations such as CRUs and using the hospice's expertise in this area. There's a lot of value in pre-bereavement support. We hear so much about advanced care planning for the person with ALS, and we try and incorporate this into our care. I'm not too sure if we are as good at talking to families to explain what death looks like and how they will build up coping strategies to cope with the devastation. I think it's fair to say that with a condition such as ALS MND, that people can experience bereavement as early as diagnosis, as there is little hope. The problem arises that ALS doesn't follow a planned course and it is unpredictable, and often we cannot know the right time to start these pre-bereavement conversations. With time so limited, we often concentrate on ensuring the patient's wishes are documented, which is right, but I'm not too sure whether we have the confidence or the time to prepare the family for bereavement. Metzer and Gray conclude that if the correct pre-bereavement support isn't given, then some people are at high risk of prolonged grief. They go on to say that when pre-bereavement support is present, it shows that families may suffer lower levels of distress. Although this is from an academic article, the message is clear and simple. It is the small gestures of compassion that people appreciate and hopefully makes a difference to them. Please can I thank the Preston MND team for all their support in the bereavement support framework. Without their time, and particularly baking cakes, a time to remember wouldn't happen. They're my details, and thank you very much for listening.
Okay, so thank you very much for your presentation, Wendy. I think we've got time for one question. If anybody has anything they'd like to ask. Yeah, we have one lady.
Thanks, Wendy. I really enjoyed that. Can I just ask you, how does it, do you think since you've done this, it helps the care team as well?
Absolutely, yeah. We find the memorial services benefiting actually because it gives us closure as well, and we feel that, you know, we've remembered those people as well. So, yeah, it certainly does support us as well.
Thank you.
Okay, thank you very much indeed for your presentation. That takes us to afternoon tea.